All to the 119th session of the weekly huddle. I'm your host, Anoop Agrawal. I am a cardiologist working at KIMS Hospital, Secunderabad. Typically, I'm joined by my colleague, Praneeth. He is not here with us right now. Hopefully, if his case gets done sooner, he will join us following. Most of you are quite familiar with the huddle format. It is an unscripted audience level interaction where we address common clinical scenarios that we encounter in our daily clinical practice. We took about 6 weeks break recently where we tried to figure out ways that we can restructure our program, which makes it more meaningful for our attendees to join. And with that, now I'm trying to include topics which are a little bit more expert in nature rather than being more general. And I'm trying to have at least one expert in our discussion who can lead our thoughts while we share our own ideas. So to my attendees, just because we have Dr. Pratik here with us, please do not shy away from sharing your thought process in terms of how you typically handle these kind of cases. And this will be my request for even future sessions where we do have an expert present, but the whole premise of the huddle is all the attendees who are taking part, they should be able to share their thoughts, their practice patterns, their understanding of how they do things, because I'm pretty sure whatever is written in the book or in the guidelines, a lot of times we are not able to follow, either because it is not tailored to our particular patient population, or there are other pragmatic reasons why we are not able to follow this. So with this background, I'm going to start the clinical case. And then Pratik sir, I will start with you only if I will ask your opinion one by one. And then in between, I'll take a few seconds pause in case if any of the attendees have any thoughts or questions or comments. So this is a case which I actually discussed with Pratik sir a few weeks back. So I just brought this question over here. So it's a 23-year-old male. He, just to give you a background history, he had a cardiac arrest about 6 years back while he was playing basketball. He was resuscitated on the field. He was taken to the hospital where, with critical care support, he made a reasonable recovery. He was diagnosed of having anomalous left main coronary artery, which had a malignant course. Following recovery, he underwent bypass surgery plus an ICD implantation because of his arrest. He now is mostly recovered and he is doing his daily activities without any major problem. So I'm on a video consultation with him. He's complaining that for the past few days, he had fever, myalgia, lethargy. He thinks symptoms started about 3-4 days ago. Now the fever is still present. It's a low-grade fever now. Earlier it was high-grade fever, but there is extreme weakness, extreme prostration. He's not able to do his daily activity because of that weakness. He is able to eat a little bit. He's able to keep oral intake. He's not throwing up. So the dominating symptoms now are mostly weakness and pain and just overall prostration. So he doesn't have any other localizing signs that might point towards one infection source or the other. He stays outside Hyderabad, and that is how I'm doing a video consultation on him. He is basically seeking second opinion to ask what he should do other than taking paracetamol. That's the only thing he's taking. Also, he's asking whether he should get admitted to the hospital now, whether he should wait for more things to be done and whatnot. So I sent some basic lab investigations on him. I'm just walking you through the lab investigations. Of course, I can't tell you physical exam findings because I'm on a video consultation with him. So the labs are as follows: his hemogram, and I've shared all of that on the WhatsApp group. If you want to refer to that, you can quickly look into the WhatsApp group. All the labs are posted there. So his hemoglobin is fine. His TLC is actually lower, 1,730, with absolute neutrophil count of 1,100. His platelet counts are 1,30,000. The renal profile mostly is okay. His creatinine is 1. His liver profile suggests slightly elevated AST/ALT, with the AST being 111 and AST being 70. His total bilirubin, protein, and other liver profile parameters are normal. His dengue NS1 antigen is positive. And amongst the serology, his dengue IgM is positive and IgG is negative. So with this, I was pretty confident that I'm dealing with a dengue fever here. And now I have to just add all these lab parameters and his clinical presentation to make up my clinical decision, what I should do for this patient. Now, I'm a cardiologist, so I, of course, don't have that confidence to make this decision. So that is where I called Pratik sir for his opinion. And I thought we are currently in this endemicity of dengue fever. I'm pretty sure each one of our attendees, they know somebody either as a patient or as somebody who is known to them in the last 2-3 months who had dengue fever. So it is all over us. And I thought it was very practical for us to discuss dengue at this time. So the questions that we are going to refer to for today's discussion are dengue serotypes. How is it relevant to us? Do we need to check for dengue serotypes? How do we clinically classify dengue fever, particularly in this kind of patient subset where we can identify who will benefit from early admission? What would constitute a significant bleeding? Because as you all know, that dengue, we are worried about thrombocytopenia and bleeding. And then we'll talk about when to transfuse, what to transfuse, and all this. We will also try to infer what these labs value mean and how to interpret that, what kind of fluids we are going to give, and all those things. So we are going to refer a lot of these aspects in the most practical way possible. So Pratik sir, I will start with the very first question, and you can take time to answer those because I don't want to rush it. I want my attendees to assimilate the information and come up with their own thoughts and come up with their own questions. So we can take time to go through it. So first of all, with the presentation and with the labs that I gave, that I shared with you, am I on the correct track? Have I made the diagnosis of dengue yet, or you think there is still more for me to explore?
Yeah, before we venture into the further discussions, I just forgot about 2-3 initial CBC values. So what was the hemoglobin PCV, the platelet count, and the I think the white cell count you said 1700 odd value. So this platelet count and the HbPCV, can you tell me that again?
Right. So hemoglobin is 13.8. PC 13.8. You got that?
Right.
Yeah.
Right.
PCV is 48.
All right.
TLC 1730.
Okay.
And platelet count 130,000.
All right, fine. So I think thank you for that information again. So basically, we have viral prodrome with significant myalgia prostration, and you have dengue NS1 positive. This is around day 3 to day 4 of symptoms, and this is the time in first 3 to 4 days you would usually get NS1 positivity, and around 3 to 5 days or 6 days is when you get IgM positivity. In the given case, you have both positivity. So definitely this is dengue. There is no dilemma in the diagnosis. It's a definite dengue. Now, when we approach the further situations, so in the classification of dengue, let's say that's the how to approach it. So whether it's a dengue, simple dengue, or it's a dengue without warning signs, what we in the current classification. So this is the recent WHO classification, which is 2009, if I'm not wrong, I think. So this is a recent classification which was like when we studied MBBS, probably then that was the dengue with dengue hemorrhagic shock and dengue shock syndrome. That was the classification of dengue, previous classification. But this one is dengue without warning signs. Can say a stable dengue. And then there is a dengue with warning signs, and then there is a severe dengue. These are the 3 broad categories of dengue overall. So we need to see which category the given patient fits in. So like in this case, if he is relatively all right and he has relatively good intake, he is able to take good amount of food and water, and he's passing urine, that means he's likely to be in a dengue with without any warning signs. And there are another thing that we need to know is what is the phase of dengue illness. Normally, you can have three different phases of infection in the dengue. You have a febrile phase, you have critical phase, and then you have recovery phase. So critical phase is not seen in all cases. Only in some cases you see critical phase. Febrile phase is obviously the name itself is explanatory when there is a fever. However, in some cases there is a critical phase where there is a lot of plasma leakage or capillary leakage, which leads to the third space loss of fluids, which can lead to the signs of, let's say, warning signs or severe dengue manifestations. So this is seen only in few cases, and these are the cases which are we should be worried when we are managing cases. So that critical phase of the disease or patients with warning signs and severe dengue is to be admitted and closely monitored and treated appropriately. And then comes the recovery phase. So why we need to see that is because your manifestations of dengue change, the way how you approach changes. So that's why these are the few things which we need to assess when we see any patient of dengue. So
Thank you so much for that introduction. I will keep working on the questions, and we will keep taking your opinion. The WHO classification that you are talking about, I have shared that as a picture. So each one of you, if you want to just review it on your screen, you may be able to take a screenshot or save it for your reference. This is what Pratik sir is referring to about. Pratik sir, my second question to you is one you mentioned about the diagnosis and the identifying these. Is it the clinical classification that we are using currently, and we have abandoned the dengue, hemorrhagic shock, and all those kind of things? Have we completely abandoned? This is the clinical utility that we are doing currently.
see, most of the places we have switched from the old classification. We usually stick to the same classification. Now, what we just mentioned, the recent one. However, still we see some people using the old classification, dengue with dengue hemorrhagic shock. So it's just using a different nomenclature. That's it. But still, sometimes we do see the old classification being used.
Then, sir, we will move on to the next question for the dengue infection. You mentioned about serotypes when I was talking to you. What is the clinical relevance of serotype? Is it something that we should be checking, we should be bothered, or is it only for epidemiology?
There are implications. So, as we know, there are 4 serotypes of dengue. So there is a very minor cross reactivity or cross immunity among these viruses. So one infection with one type of serotype does not give you a protection against other types. So practically, we can have dengue at least 4 times in our lifetime. A person can still have 4 times. And after the first infection, any second infection, if you get, that is likely to be a serious infection because it stimulates the immunity more. So the any secondary dengue, as we call it, can have a severe manifestations. That's why we need to be careful in managing those patients. Anybody who had history of dengue, or if
Pratik, sir, we lost you now.
am I audible again?
Yes, you are.
Yeah, okay. So that's one. That's why we need to know. However, we don't need to know which serotype infection I had or somebody had in the past. So that 1, 2, 3, 4 doesn't matter in the clinical management. So whether it's just IgG positive or not, that only helps it. So we don't need to know particular serotype in the routine clinical management. However, it may help us in vaccine scenario. Let's say there is a dengue vaccine which has been approved by WHO in some countries, especially Mexico and some Southern American countries. It has been approved and is being used. However, in India, it's not been approved for reasons because it doesn't give you the protection against all serotypes. So we need to know the background, and it is not effective against certain serotypes. Like I think 2 and 3, it is not very useful. Against serotype 1 and 4, it is more useful. So that is the reason. But in clinical management of active patients with infection of dengue, it is not useful.
Thank you, sir. Then we will go towards back to your clinical classification, because my next question is pertaining to that. I told you the clinical scenario of this patient. I told you the labs that were available to me, and you have shared the WHO classification that you are using right now. Are you deciding whether
Yes.
which patient should get what kind of treatment based upon this classification? Can you fit my patient into this particular classification and decide whether you want to treat him at home or you want to treat him in the hospital?
Yes, that's the reason why the WHO classification has been changed. This is more clinical oriented classification, you can say. So if the patient is not a high risk, or if he does not have any warning signs, then probably you can just watch the patient at home, ask him to take plenty of oral fluids and symptomatic treatment like a paracetamol or any antacid or antiemetic. That should be fine. And explain him what are the warning signs. If at all he manifests any of those signs, to come back to the hospital so that we need to admit him. So that is the exact intention why these are the classifications made more clinical than the previous classification. Let's say in your case, the patient did not have any warning signs, which are easily, like if he's not able to eat, if he's too lethargic, if he's vomiting out too much, his output is not much good, if he's extremely lethargic or restless. Extreme lethargic means he's not able to get up, he's not able to eat anything. That is what I'm saying, extreme lethargy as such. Or if there is any abdominal pain or distension, that can be a sign of third spacing or accumulation of fluid in the abdomen, or any respiratory distress which can happen due to the pleural effusions. So these are the things which we need to explain to them, so that if there is anything new, they can come back. And obviously the mucosal bleedings, like if there is any bleeding from the nose, or if there is any gum bleed, or any hematuria, or any blood in the stools. So these are all things we need to explain to the patients. And if they don't have any of these, they can remain at home and just watch for these symptoms, take adequate oral intake. So that oral intake has to be really stressed upon. Liquids around 3 to 4 liters, depending on the weight and overall body habitus. That has to be emphasized, and we can monitor it further.
So I'm reading these warning signs which are there on the page that I have shared. It says abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, restlessness, liver enlargement more than 2 centimeters, and then lab value of increase in hematocrit concurrent with rapid decrease in platelet count. Pratik sir, I'm going to ask you these definitions for the laboratory, but before that, you mentioned bleeding episode. Few of the bleeding episode you mentioned, mucosal bleed and all this. Uh, Tell us, what is this mucosal bleed? A patient who has, let's say this boy, he's brushing his teeth and he got some bleed from his gum. Is that mucosal bleed requiring admission?
See, I would say that the mucosal bleed, like I said, it can be gum bleed as well. In this case, what we need to do is just check the platelet count and the routine CBC. If it is brushing too hard, or somebody who has a history of gum bleed, may not be significant. If somebody has gingivitis or carious tooth, they may not be having this may not be a significant event. However, somebody who never had such issue, but has a new onset epistaxis or even gum bleed, even on very soft brushing, probably it's an early sign. So that way you have to see the whole picture rather than just one finding. Same way,
And then,
especially in women, like what we say, the menstrual bleeding. If it is expected menses, and if it is not heavier than usual, it's not to be supposed as a bleeding manifestation. However, if there is any excessive flow, or if it's not expected on the due date, and if it comes early and it's abnormal bleeding, then it has to be considered significant.
then the question is again going to the bleeding part also. How about skin rash? Is it subcutaneous rash? Is it part of bleeding manifestation?
No. Now, when we talk about this rash in dengue, there are two patterns. One is the erythematous diffuse rash, or the the dengue toxic rash, what we can say. That is a different rash for which you don't need to do anything. Okay. However, the platelets, when they drop further, you can see the petechial rash that also can come. And both of these are not suggestive of any significant bleeding. So presence of platelets does not mean there is a bleeding. So mucosal bleeding is yes, but cutaneous, like skin manifestations like petechi, it's not significant bleeding.
And then, sir, going towards the lab story, increase in hematocrit and rapid decrease in platelet count. How do you define that? What is high hematocrit and what is rapid decrease in platelet?
See, this is the, I mean to say, the hematocrit, anything above 50 has to be considered significant. Okay. And rapid decrease in the platelets is more than 20% from the baseline.
And you mean that is 20% every day, every 24 hours, right?
Yes. Yes.
So do you advocate checking platelets every 24 hours in these cases?
Sorry.
Do you advocate checking platelets every 24 hours in these cases?
First, usually, I'm telling you, most commonly is, let us say, first 3 to 4 days, usually the trend, what we say, the natural history of the dengue infection. Let's talk about that first. So initially, you see the start is like low white cell count. So first your white cells count drop and followed by the platelets. So your platelets will go to a significant low level probably after day 5, and your white cells start dropping same time just before that. So now, why I don't know. I mean, the problem is we see everybody, if you see the dengue, they will first question us, what is the platelet count? However, it's a wrong notion. First of all, uh, platelets are not as important as they are given importance in the management of dengue. Obviously, they drop, but the requirement of platelet transfusion is usually not there unless they drop to less than 10,000 or there is a significant bleeding that you see. Unless that happens, you are not supposed to transfuse platelets. Again, how much platelet transfusion is useful, that is not very guideline based, or that is not evidence based. There is not much evidence that platelet transfusion alone helps. There is a guidelines. If you see the guidelines, they recommend about blood transfusion in patients who have significant bleeding and if there is any shock. So whole blood or a packed RBCs has to be transfused in these patients. And yes, you can support with platelets, but that's not the whole. So platelets alone is not important. You have to consider PRBC as well if there is a significant drop in the hemoglobin. So that has to be emphasized. Now, the how to monitor? The monitoring has to be for the hematocrit, not exactly for the platelet count. Why we need to monitor the hematocrit, or let's say PCV, is because you need to assess the intravascular volume of the patient, because the complications happen because of the drop in the intravascular volume, that hypovolemia. So to assess the third spacing, you see the hematocrit rising. If it rises more than 50 or more than 20% from the baseline, that is a significant intravascular volume depletion, and you need to be aggressive with your fluids. That is what is the take-home message from this. Why you need to monitor? So it's not for the drop in the platelets. So we need to drop. HbPCV is what is normally recommended to see every day.
Sir, what is the rationale behind hemoglobin dropping in dengue? Why would
No,
hemoglobin drop?
normal. No, there are two phases in this. In febrile phase and in critical phase, usually the hemoglobin rises because the third spacing of the fluid. Normally, because the capillaries become leaky because of the dengue virus infection, the fluid from the intravascular compartment goes into the third space, like pleural fluid or abdominal, intraperitoneal compartment. So that causes the hemoconcentration, and that causes the rise in the hematocrit or the PCV, and that's why when you do a CBP, your hemoglobin rises. So
And
it's
at some point,
and
it
that
would
is when in the initial critical phase. However, once you give the fluids, it slowly improves. So that is why when you are giving the fluids in dengue with warning signs or in patients with severe dengue, you monitor hematocrit. Your target hematocrit should be less than 50, so that it ensures that your volume, intravascular volume, is adequate.
And sir, what is the how do we put LFTs into this equation for clinical decision making other than saying it is bad?
Usually, it's common to see that around 2 to 3 times elevation in the liver enzymes, particularly SGOT and SGPT. So, but in severe dengue, it can be very high. Sometimes, let's say, more than 1,000. That is the definition wise. You can say that liver enzymes SGOT and SGPT more than 1,000 is suggestive of a severe dengue. So you can see that how significant it is. There are many patients with dengue. If they have severe abdominal pain, it is possibly pointing towards hepatitis coexisting with the ascites. So you can you can monitor the LFTs in them. If they are seeing that there is a rise, progressive rise in the LFTs, that indicates hepatitis, possible coagulopathy, because that can cause the increase in the APTT and PTINR and possible hepatic failure. So this is why you need to be careful if there is a rising titer of the liver enzymes.
And are these liver enzymes by itself would suffice the criteria for admission, or there has to be associated clinical syndrome along with it?
Usually they are associated with the clinical symptoms. If let's say for 2 to 3 times admission rise in the platelet, SGOT and SGPT should not be a reason for admission. However, if the patient, see, in general, if the patient has persistent fever for more than 4 days, or if he has any warning signs, that should be the criteria for admission in dengue. If somebody has fever for shorter duration, and if they are able to maintain their volume status with oral liquids, I don't think there is any requirement of admission in the hospital.
And sir, one question that I asked you during that day when I was talking to you, I'll ask you here for my attendees to hear. I asked you about role of antibiotics in these cases because, as you can see in this particular patient, the white cell count is 1,700, neutrophil count is 1,100. This gentleman is having fever. It's day 4, and while dengue serology is positive, I am worried about secondary bacterial infection. So, is there a role for antibiotics in these cases?
Usually not, because this is a febrile neutropenia by definition. Though in patients, this is due to the acute viral infection and it is likely to recover. The febrile neutropenia, you need to give antibiotic prophylaxis or treatment, let's say, when you expect the neutropenia to persist for 7 days or longer, or if it is due to the chemotherapy. So in dengue, usually as a prophylactic, there is no role of either antibiotics, no role of any steroids, or no role of even neukines or the granulocyte colony stimulating factor, GCSF. No role of either of these three.
And the rationale in these cases is because you expect this neutropenia to not persist for long period of time. You expect it to improve within a day or two, right?
Yes.
Okay.
And another reason why is it different from the conventional neutropenia that we commonly see in the chemotherapy patient is because in those patients, the neutropenia usually coincides with the gut mucositis. Because their gut mucosa gets eroded due to the chemotherapy, that's why they are highly at risk for the gut translocation of the bacteria from gut into the blood. That's the reason any fever in these cases we take very seriously. It's a medical emergency, febrile neutropenia. Same time, it's not the pathology in dengue. That's why we don't treat it with antibiotics.
Thank you, sir. I'll just take a pause here to my attendees. I am sharing a PPT slide, what Pratik sir shared with me. This is some of the bullet points that he thought it is important for us to highlight. So again, if you want to take a screenshot of it, they're very basic, but it kind of drives home the point. Pratik sir, asymptomatic thrombocytopenia, it's a very, very commonly asked question. When to transfuse in this 23-year-old gentleman?
I would wait if he's stable till 10,000 at least. Okay. And it depends on how the patient is. So let's say if I'm seeing a steady rise in the white cell counts for maybe a couple of days and it is reaching 10, but there is no fever, there are no other warning signs, he is comfortable, then I would even wait, even if it's slightly less than 10,000, maybe maybe around 7, 8,000. But I know that white cells have started improving and the platelets are going to follow the trend. So I would wait even in that situation. But in general, for practical purposes, 10,000 should be your threshold without bleeding. Obviously, if there is a bleeding, probably you can consider it early. You can consider transfusing platelets only if there is not significant bleeding to cause a significant drop in the hematocrit. However, if there is a drop in the hematocrit and HB significant drop, make sure you transfuse PRBC or the whole blood.
So, I hear you going down all the way down to 10,000 or 8,000 and whatnot. My question is, why to be that brave? Why not start transfusing at 20, 25,000? What is the harm?
Yes, there is definitely harm. First thing is there is no evidence that platelet transfusion helps. That's one. Second, any transfusion, especially in dengue, can cause transfusion-associated lung injury or fluid overload. What happens is in dengue there are different. See, we discussed about the hemoconcentration that happens, the third spacing of fluids in the critical phase, right? But when there is a recovery phase of dengue, all the fluid which has been third spaced into the peritoneal cavity, or let's say the pleural fluid, it is reabsorbed back into the vascular compartment, and that is the time where you should be even more watchful about the fluids. So you give more fluids during the critical phase. You should be very aggressive with fluid management in dengue in critical phase. However, once the critical phase is over, you should cut down your fluids rapidly, because the fluid comes back into the vascular compartment, and in this time if you give more fluids, they can go into the pulmonary edema. So that assessment of fluid status and the disease stage is very important, so that you can direct your fluids accordingly. So if you give additional fluid, let's say if the patient is relatively well, just because platelets are low and he's in recovery phase, you give more fluids, especially a colloid, let's say the plasma or the platelets, then you may push the patient in either into the pulmonary edema. He may have a transfusion associated lung injury itself, and platelets will not help you for more than 24 hours. The shelf life is very less, and when you transfuse, they will anyway will not last for more than 24 hours. So it doesn't help you anyway. So that's why the clinical assessment of the given patient at that point of time is very important. What stage, what is the current stage of illness?
You mentioned about fluid resuscitation. What is your thought about giving IV fluids at home in this kind of patient subset?
I wouldn't do that, because if you think really the patient needs IV fluids, preferable to admit the patients and do it, because you need it's not a simple IV fluids administration. It has to be very dynamic in patients who are, let's say, a critical phase. You need to follow the CBC, the particularly the HBPCV every 8 hours or 12 hours. Guidelines will say every 6 hours also. If it is really critical, you have to do that. So your fluid resuscitation depends on that, because if it is a patient who is in severe volume depletion or in shock, you may have to give a lot of bolus fluids and then reduce accordingly this thing, because the fluids, there are different rates. If you read the guidelines, in the different phases of patient scenario, there are different rates of fluid administration on hourly basis. So that is very closely to be done. Ideally speaking, that's why if any patient who really needs fluids, better to admit.
And am I sensing from what you are saying that when these patients are admitted, are you dumping fluid like more than 3-4 liters a day? Are you needing to dump that much fluid in the body?
If the patient is not able to take orally, if he's throwing up and he's in a febrile or a critical phase, yes.
Okay, and you think that 3-4 liters of fluid probably should be done in the hospital rather than at home? That's probably a better option.
Absolutely, yes.
Okay, all right. I'm inviting any questions or comments from any of our attendees. We have covered most of the topics that I highlighted in my invite on the weekly huddle WhatsApp group. But if there are any questions or any comments or suggestions for what we have discussed so far, please feel free to unmute yourself, raise your hand, or type in your question. And Dr. Shankar, I actually was coming to you only, so I'm glad that you unmuted yourself. My question to you is, first, your comments about this topic. You heard Dr. Pratik sharing his thoughts. My question to you is the very last question that I asked Pratik sir. IV fluids at home. Why is Pratik sir not liking that? Because sometimes we do give IV fluids at home because we don't want every patient to get admitted and everything else looks fine. What is your thought on it? Are we going to harm them more? Shankar sir.
I am audible. Am I audible?
Yes, sir. You are very much audible.
Good evening to all. At the outset, I congratulate and thank Dr. Anoop Agrawal and Pranit Polamuri for restarting huddle session, weekly huddle session. Dr. Satish has covered this dengue fever at length. Only thing is regarding IV fluids at home, because the monitoring is needed, as suggested by Dr. Satish also, because we should uh, we should be very careful regarding the warning signs. So they will, if they are there, because they should be closely monitored, and if they are there, then he will pass on to, he will progress to severe dengue. So that's why, so IV fluids should be given under close supervision by the healthcare personnel. And at the same time, uh, so the platelet concentrate, recent guidelines by the World Health Organization and PAHO, that is the Pan American Health Organization, they have passed guidelines recently, only 1-2 months back, regarding the management of dengue. And the platelet concentrate is not necessary irrespective of the platelet count, except if there are chances of bleeding or patients progress to bleeding conditions like pregnancy. But in clinical practice, when at any amount of this platelet count, we, if the bleeding is there, then we transfuse. Second thing is, below 10,000 without bleeding, or 20,000 with the bleeding. In clinical practice, we advocate platelet-rich concentrate, SDP. And at the same time, a platelet, so not patient regarding the bone marrow recovery. So like mean platelet volume and the platelet distribution width, PDW, MPV, and platelet to large cell ratio, because the young platelets or the immature platelets will have pseudopodia and the larger in size. So platelet to large cell ratio, that is a PLCR, and immature platelet fraction, actually, immature platelet fraction. So these platelet indices should also be monitored so that we can find out whether the patient is recovering or not, whether that indicates that the bone marrow recovery. So apart from the platelet count, HB, PCV, or HCT. Then these platelet indices also should be monitored so that we'll be confident enough that the bone marrow is recovering. Thank you. And one more this thing, dengue at present we are not advocating, but in few of the countries it is approved by even US FDA also. 3 doses should be given, 0, 6 and 12 months. Especially in the persons aged between 9 to 45, particularly 9 to 16 years of age, and confirmed previous dengue infection. They should be infected with the dengue virus previously. Otherwise, we should examine whether they were infected or not. Then only we should give in the patients of secondary infection or heterotypic infected patients only, we should advocate this dengue vaccine. So there should be serological evidence of seropositivity in these cases. Thank you. Dr. Satish has nicely covered. Nothing to add. Only thing is the recent guidelines. So regarding the crystalloids versus colloids, but all the guidelines they advocate crystalloids only, normal saline, ringer lactate. Other than only except in acidosis, then 5% dextrose and dextrosaline. These are crystalloids can be given in the fluid management resuscitation of dengue patients. But home care management, we should advocate intense oral hydration regimen. We regularly follow this holiday cigar formula. So first, the 1 to 10 kg, we give 100 ml per kg body weight. Then second, 10 to 11 to 20 kg, we give 50 ml per kg body weight, 40 ml per kg body weight. Then next 21 to any number, we give 20 ml per kg body weight. This is the holiday cigar formula we follow in hydration or in the resuscitation of the patient with the fluids, either orally or parenterally. Thank you. Thank you, Dr. Anoop.
Shankar sir, I have 2 questions for you. Number 1, talking about platelet transfusion, I'm fascinated with the discussion which is happening about 10,000 and 8,000. With the kind of setup that you are practicing in, a patient with dengue admission, platelet count of 30,000, how difficult it is for you to convince the patient or the family that you don't need platelet transfusion?
But there are guidelines. It is not the platelet count, but only the bleeding manifestations we should treat. So thrombocytopenia alone is not the factor, but other factors also should be taken into criteria. The pathogenesis of this dengue is vasculopathy and coagulopathy. They should be tackled. So definitely, but that's why I'm telling you, though the guidelines they tell irrespective of the platelet count, there are no indication for the platelet transfusion. But in our clinical practice, if it is a 20,000 platelet count with bleeding manifestations or less than 10,000 platelet count, I transfuse SDP.
Thank you so much, sir. I will go back to Pratik, sir. In the meantime, if anybody has any questions or comments, please feel free to share. Pratik, sir, any immunoglobulin that we have identified yet for dengue treatment? Any IVIG or anything that you know?
No, not.
Anoop, this is
No.
Somaraju.
Pratik, sir,
Sorry
1
for
second.
interrupting.
Somaraju, sir, please go ahead.
We have been listening to the experts and some of you. As is usual, we in tertiary care do not seem to be interested in prevention. And please do talk something about the practical aspects of prevention for many of us who are not involved in this, and also including the status of vaccine. Don't do the same mistakes we have been doing all our life. Please talk about prevention.
Thank you, sir. Definitely, we will be talking about prevention as we move forward. Pratik, sir, IVIG for dengue fever.
No data so far, no use. Only in few scenarios, let's say sometimes when we see the dengue with HLH, in that scenario, there may be some evidence, but nothing dengue specific IgG. It's just the routine IVIG. But in general cases, no use.
Then the other question that Somaraju sir mentioned and Shankar sir also mentioned, what is your thought about vaccine in India? You mentioned that there are reasons why it won't be applicable in the current form, but do you know any inside story of vaccine coming up for us?
Yes, I mean, see, the reason is first, we don't have a very good epidemiological data of serotypes prevalent in India in different parts. Now, India is a huge country, and there are different strains predominant in different areas. Like I mentioned, it is not effective against all 4 serotypes. And like Dr. Shankar mentioned, it is a vaccine which is useful only if somebody had dengue in the past. So you have to have a confirmed serology positive IgG, then only you should take vaccine of dengue. Otherwise, in patients who were not previously vaccinated, it has shown to increase the risk of hospital admissions and severe dengue. So that is the risk. So if somebody gets primary dengue after dengue vaccine, the primary dengue infection works as if a secondary infection, and that's why you see more complications and more hospital admissions. So that's why it's a mandatory thing to know the serology prior to giving the dengue vaccine. So, and again, it is more useful in the pediatric, I think 9 to 15 or 16 years population, it is more useful. So it's not useful in across the age groups. So these are the different things which we need to know before advocating dengue vaccine. So this is the precise reason, though we have so many cases of dengue, the government is not launching the dengue, or the ICMR is not approving the use of dengue in India, because these are the practical roadblocks we have in dengue management in India. So how to stratify that, who has been given, so you need to do lot of testing. So that is the reason it is not being approved in India so far.
And then, sir, last
Dr. Anoop,
question.
sorry for interruption. We went through similar situations with COVID. Our lack of information adequate. Still, we developed vaccinations, and also even H1N1. What is available versus what is talked about, what is right, and while that information was not adequate, we still have vaccines for which there is no 100% evidence of benefit. Still, it helps 40 to 50% of patients. So this argument, I don't agree, that it should not be made available just because you don't know enough information.
Can I have this thing? Sorry,
Pratik, sir.
Yes. We have information. It's not there. It's not that we don't have any information. But the problem with the dengue vaccine particularly is because it can backfire. We have information about serotypes in certain areas. It is available. But only thing is, you have, before considering vaccination in the given population, we have to do lot of sero surveys and serological tests in all the vulnerable population. Now, if you see that vulnerable population, it's anybody. So in that case, so that is the reason government is not approving it yet. That's why it's not commercially available in India. At least if they make it available as a private practice, or those who want to go for it as an individual, we have a choice of doing that. Anybody eligible, if we do a test, if it's positive, probably we can still suggest those vaccines. But we have eligible population, we can use it. It's not that we cannot use it, but government for these reasons is not approving, because it will involve lot of work and probably lot of funding.
So Pratik sir, my question to you is, now I'm taking Somaraju sir's side. See, when I was in my undergraduate in 2006, New Delhi saw a huge endemicity of dengue at that time. I remember at that time we catered to some 16,000, 18,000 dengue patients over few days. That main AIMS hospital literally was flooded. Every single bed had dengue at that time, something like what we saw in COVID. But of course, because dengue was more regional, it was not spread out in all across India, but there were few pockets. We have been hearing dengue since we entered medicine, and there had been these episodes of these blasts of dengue all across. I certainly can see that even government would see the urgency of why we need to work on dengue. Is there something fundamentally difficult about this virus like HIV where we are not able to come up with a virus, or you think it is pure lack of funding intent or whatnot? What is your thoughts on this?
I think the dengue vaccine is reasonably good vaccine against if you are using it in a given population and in a given setting. It's probably much better in terms of the immunogenicity. However, it's the different serotypes that you have, and it is not effective against all serotypes. I'm not sure about why it is not good enough and what is the exact immunological mechanism of different response to the different serotypes. I'm not aware about that. So it is not a very useful vaccine as compared to the flu vaccine or this thing. There is no efficacy. So probably when you see government, always there is a risk versus benefit or cost benefit that they have to consider.
So as of right now, even if I want a dengue vaccine, it's not available in India, correct?
It's not. So that is what I was trying to make a point. At least if government permits to be available, to make it available, it need not be available under the government should not give it from their pocket. For those who are interested, they are eligible and ready to pay for it. I think it is fair enough to make it available.
And because we don't know much about the vaccine as much as you do, particularly for dengue and the vaccine both, let us say if this situation does come where vaccines are available at purchase on an individual, based upon your current level of understanding, do you think you would recommend all of us to get our IgG level checked and after that get the vaccine done? What is your take on that?
Probably yes. See, again, it depends on what is your risk. So benefit is not seen. See, that is the reason, again, government is not approving it for all, because the benefit is best seen in the small population, in certain age group, young age group. It's not seen across the different age groups. But what is the harm? We don't know in this population. There are not very big studies to say what is possibly, but like sir said, we have used COVID vaccines without much information. Why not dengue? Point taken. I think it's fair enough. We can try it out. To those who are willing, at least they will be registered as a trial. We can try it. Why not?
Thank you, Pratik sir. Sumaraju sir, I do have a couple of questions for you. You shared your thoughts on the topic today. My two questions pertaining to dengue and cardiology. So this 23-year-old gentleman who is post-bypass surgery, he takes a low-dose aspirin daily. In the context of dengue, what is your thought on aspirin and thrombocytopenia? At what point you think it should be mandatorily stopped, or you think there is no platelet count at which we have to stop in these kind of cases? What is your thought on it, Somaraju sir?
If it is post-bypass surgery, is it?
Yes, sir.
When was the surgery done?
Surgery was done 6 years ago, sir.
So if it is bypass surgery, the answer was simple, straightforward. Be more conservative and say stop the medication, aspirin or any antiplatelet. The issues are more difficult with angioplasty, recently done, etc. And there you have to go by what Dr. Pratik said, wait for the platelet counts to come, because the risk of stent thrombosis versus the risk of serious complications with dengue, you have to weigh. Each individual patient, you have to go by that, and more than one of us should be involved in it. do keep in touch with a physician or an infectious disease specialist and work together. The more difficult question, as I said, is in the setting of say previous stenting and the duration of stenting, etc. And burst bypass surgery is simple, straightforward. The moment you have a confirmation of dengue, whatever is the platelet count, I would stop antiplatelets. Thank you.
And sir, the second question pertaining to cardiology comes not for this patient, but very recently there was a patient in our ICU, medical ICU. She, I believe, is 27, 28-year-old female with all the dengue features that we talked about, but severe myocarditis with the ejection fraction noted to be around 30-35%, global hypokinesia, and she was requiring inotropes and whatnot to maintain. She did come out of her acute episode, but I was scratching my head that is there something dengue specific that we can do to help this kind of myocarditis patient other than supportive care? Somaraju sir.
I'm sorry, I don't know the answer for it.
Pratik sir, anything dengue myocarditis? This may not be a question for you, but do you expect us to do anything other than the routine supportive care?
No, I don't think anything particular as such. Nothing. It's just the routine supportive care. Wait for it to recover on its own.
So I remember back in the day where viral myocarditis, not particularly dengue myocarditis, where we have bridged these patients with external mechanical support devices for a few days to even weeks or two, just so that like what we were doing in COVID, we were doing with ECMO for lungs. Here we have done it for mechanical support device for the left ventricle and sometimes for right ventricle as well, for those ventricles to recover. And that typically we end up doing when the cardiac output is so low, even while being on inotropes and whatnot, that we are not able to maintain forward perfusion. So in those cases, while we wait for the viral phase to recover, we have to support the hemodynamics, and that often requires mechanical support. I'm glad that that wasn't the case, at least in my short professional career. It wasn't more than a few times, but I'm pretty sure to my seniors, they probably have seen more than a few times where patients required external mechanical support to tide over the crisis, as to speak. Those were all the topics that I had. And Pratik sir, one question I didn't ask. So what kind of IV fluids you give to your patients if they're admitted in the hospital? Do you have a standard protocol?
Like I think Dr. Shankar mentioned, it's the crystalloids, which is the drug, the fluid of choice. It can be just a normal saline, or in some cases, the plasmalite, which is used commonly, which is more physiological fluid, we can say. These are the crystalloids are preferred. We usually don't use the other colloids unless somebody is in a refractory shock. So that's what I would say, crystalloids.
And there is nothing like plasmalite is better than ringer lactate is better than normal saline, nothing like that, right?
No, if you are giving too much and if there is patient is not able to, if the patient is looking acidotic, the only risk factor with the normal saline is the hyperchloremic acidosis. If the patient is looking all right overall, then you don't need to worry. Plasmalite is a better option, especially in critical patients who are in the ICU. But again, it's additional cost. So if it's a ward patient, probably simple normal saline or ringer lactate should be fine. In ICUs, probably you can prefer plasmalite.
Thank you so much, sir. It is 8:04. Any other questions, comments about today's discussion that we can hear from you, or we can ask Pratik sir for his comments? Maybe just a few seconds. I'll take a pause. If you have any questions, you can please share. And let me take this opportunity to thank each one of you for participating. This is our 119th session, and we already have the schedule out for this month, which is November. As you know, we have been doing this for quite some time every Wednesday. Earlier, we were starting at 7 p.m. Now we're starting at 8 p.m. As per the feedback that I have got. And I'm trying to make sure that we do have few media outputs, either in the form of flowcharts or PowerPoint, which we can share it with you. The basic premise of Huddle was not to make it a presentation, not to have a PowerPoint where you do a 30-minute presentation, because that you attend plenty. The idea of the Huddle was to have a more interactive session where we go beyond the science, where we talk about what we can do practically and whatnot. So thank you all for bearing with me. All these sessions I'm recording and I'm actively putting it on our YouTube channel and our podcast. I am running behind schedule, but I'm trying to put one session recording every 3 or 4 days. So maybe in the next 1 month or so, I'll catch up. And then hopefully I will be able to put a live recording on the YouTube as well. So thank you all for attending today's session. We will be back live next Wednesday at 8 o'clock. And I don't know if Praneeth is logged in yet. Praneeth, if you are, you can probably say one last word before we close the session.
Yeah, I'm there. Thank you. And I'm there since few of the last discussion. It's good to be back. It's always nice to hear the practical aspects of managing. Thank you for the inputs from Dr. Pratik and Shankar sir. I think it was a very interactive session, and hopefully with this session, our strategy of managing dengue will be a bit better and a bit more confident. Thank you, everyone.
Thank you all. Good night. We will see you next Wednesday. Take care, guys.
Thank you. Bye.